Professor Yasman is talk about diabetic retinopathy diagnosis and management.
Morning. So I'm going to talk you through the management of the diabetic triopathies. Diabetic triopathy, or what I call the unholy trinity, is essentially looking at neuropathy, nephropathy, and retinopathy. But there is actually a very common link between these three complications, microvascular complications, and the macrovascular complications. And I'll show you the common link in a recent paper that's just been published in The Lancet. So this is an analysis of almost 50,000 patients, type 2 diabetic patients, in a GP database in the UK. And Jack Brownrigg's just published this paper. And what it emphasizes is the importance of looking for microvascular complications. And the reason is the following. If you look at outcomes in patients with type 2 diabetes for heart failure and cardiovascular mortality, then traditionally we always think about coronary disease risk factors like hypertension, lipids, glucose control. What you see here is actually that the traditional risk factors like systolic, diastolic blood pressure, BMI, HbA1c, smoking history, do increase your risk of heart failure, but the presence of microvascular complications, that is 1, 2, or 3 microvascular complications, actually really far exceeds the risk of heart failure if you have these complications as opposed to not having them. And again, cardiovascular mortality, the traditional risk factors like blood pressure, HbA1c, smoking, increase your risk of cardiovascular mortality, but the presence of microvascular complications, when it's 1, 2, or indeed 3, markedly increases your risk of cardiovascular mortality. And I think that draws together, really, the fact that many of the complications that we see in terms of microvascular complications, and in particular neuropathy, have actually got common vascular risk factors. So it's not just glucose control. I mean, the previous colleague talked about how we as endocrinologists should improve glycemic control. I think we've got to move away from that. Glucose is important, but actually the treatment of risk factors like blood pressure and even BMI, total cholesterol and lipids is as important, if not more important. So for example, this is a study looking at the risk factors for neuropathy. You see, glucose control is important, but blood pressure control is actually more important than improving glucose control in the development of complications. And indeed, if you look at the peripheral nerve, you see that microvascular disease actually is an important part of driving nerve pathology. And we showed this actually many years ago in probably too long, 1989, we published a paper where we showed the extensive endoneurial microvascular disease that's present in peripheral nerves of patients with diabetes. And indeed, what you see is progressive microvascular disease, which is leading to hypoxia in the peripheral nerve, much like in the heart or the brain. So, as a result of these observations, we actually performed a clinical trial in which we showed that treating diabetic patients with mild neuropathy with an ACE inhibitor could actually improve neuropathy. So what we did is we randomized patients, type 2 diabetic patients, to the ACE inhibitor trandalapro and watched over 12 months what happened to their nerve function. And in fact, when you randomize these patients, what happens is you are obviously improving their blood flow, but as a consequence, you're actually improving their motor nerve conduction velocity, their M wave amplitude, and the F wave latency. So, suggesting that use of ACE inhibitors should be more common because it actually not just prevents or helps nephropathy and retinopathy, but also neuropathy. And in fact, there is a subsequent study called the DEMAND study from Italy, which took 380 hypertensive type 2 patients without nephropathy and treated them over 4 years. And they treated them with not just an ACE inhibitor, Delapril, but also manidipine, which is a calcium channel blocker. And what they did is they compared a combination of manidipine with Delapril, or Delapril alone, or placebo over 4 years. And in terms of neuropathy, actually they showed a significant 40% reduction in the development of neuropathy if you were on a combination of manidipine and Delapril. And indeed, if you were on Delapril alone, you had a 48% reduction compared to those on placebo. Again, emphasizing the importance of treating patients with blood pressure lowering agents, particularly ACE inhibitors and calcium channel blockers, in preventing the development of neuropathy. And indeed, not just blood pressure, but also lipids have been shown to be important in the development of neuropathy. And this one actually doesn't project well, but triglycerides actually increase your risk by about 20%. And so, again, when we think about lowering cardiovascular risk, we treat with statins to prevent atherosclerosis, but there is evidence that shows that in fact triglycerides may be exerting an independent effect on neuropathy. And indeed, there is a large clinical trial called the FIELD study, which was undertaken as a multinational study predominantly in Australia, which actually randomized 4,895 type 2 diabetic patients to fenofibrate or placebo. And the amazing thing that they showed is actually that if you were on fenofibrate, you could reduce your risk of minor amputation by almost 50%, suggesting that treating patients with fenofibrate has an impact on the triglycerides and perhaps also an independent effect, but actually can lower your risk of amputation, and therefore the effect is mediated by an effect on neuropathy. Carpal tunnel syndrome actually is something that we all come across as clinicians, and we all kind of have difficulties in managing particularly diabetic patients. So carpal tunnel syndrome is the most common entrapment neuropathy. We know it's more prevalent in diabetic patients compared to the general population. But the question you often have to ask is, why does it happen in diabetes more commonly, and what could be the underlying mechanism? Traditionally, people think about the flexor retinaculum compressing the median nerve, and so the treatment actually is you either transect the flexor retinaculum and you relieve the pressure, or you give steroid injections to reduce the edema to change things. Now, we've actually done a study which looks at a different, so this has just been published about 2 years ago. We actually looked at the expression of certain growth factors, particularly vascular endothelial growth factor, in nerves that are just lying adjacent to but not compressed by, not that we couldn't take a bit of the median nerve, we had to take a portion of the posterior trochleus nerve. And what we showed actually is that there is increased expression in the patient with carpal tunnel of vascular endothelial growth factor and the receptors for vascular endothelial growth factor. And you can see this here in the diabetic patients. You can see significantly greater expression of VEGF and the two receptors compared to non-diabetic patients with carpal tunnel syndrome. Now, the logic from that is, and we have to do a clinical trial for this, actually, if you look in the world of retinopathy, there is now established treatment with anti-VEGF therapy. So if VEGF is playing an important role, and we know VEGF actually, increased expression of VEGF will result in edema, then what I would say is that actually the thing that we need to do is to consider a clinical trial where we're actually maybe injecting, rather than steroid, some of this anti-VEGF therapy around, not in the nerve, but around the nerve to perhaps reduce the expression of these vascular growth factors and perhaps relieve carpal tunnel. In terms of the other complication, which of course we see in about a third of our patients, painful neuropathy, characterized by these typical small fiber symptoms. The current guidance actually is pretty much the same as 10 years ago, but the most recent guidance is just about to be published in Diabetes Care, which I was one of the writing group, is the 2016 ADA Diabetic Peripheral Neuropathy Consensus Statement. And essentially, this is, once you've diagnosed patients with diabetic painful neuropathy, you have three choices: pregabalin or gabapentin, duloxetine or venlafaxine, or the tricyclic antidepressants, nortriptyline and cypramine. And you can use either of these agents. If you have no clinically meaningful effect with either of these agents, then you need to switch to another agent. And by that, I mean if you already have tried an SNRI, it's no point trying a tricyclic. You need to try pregabalin or gabapentin. If, however, the alternative agent doesn't work, then actually there is limited evidence, but there is evidence to suggest that combining two different agents might be of benefit. And the two different types of agents we recommended to combine are, for example, duloxetine with pregabalin with lower doses to try to achieve a beneficial effect. If this doesn't work, then you can consider either the tapentadol, which is now the third approved drug, FDA approved drug for painful neuropathy, and or tramadol. And if you have no clinically meaningful effect there, then you refer to the pain clinic. So that's the current state of play for painful diabetic neuropathy: pregabalin, duloxetine, or tapentadol. But sometimes obvious conditions and treatments are the most difficult to grasp. And by that, I mean the potential role of vitamin D. And we have done studies which show that if you have diabetes and painless neuropathy, then your vitamin D level actually is comparable to controls. If, however, you have painful neuropathy, then it is significantly lower in those with pain compared to those without pain. And so, logically, you would say, well, if that's the case, if there are low levels of vitamin D, then maybe treating these patients with painful neuropathy with vitamin D might improve their painful neuropathy. And in fact, if you look at vitamin D deficiency, the levels, if it's less than 20 nanograms per mil, then your odds ratio of painful diabetic neuropathy is almost 10-fold greater. If it's less than 30, then it's 5-fold greater. So this is a real impact in terms of low levels of vitamin D on painful diabetic neuropathy. And in fact, we've done a study, and we've published this, where we've shown that if you do give vitamin D, and this is high doses of vitamin, 600,000 international units intramuscular, given to patients who actually had reasonable levels of vitamin D. Follow-up over 20 weeks, what you see is that the total McGill pain score falls significantly, the pain score falls significantly, and so do the positive symptoms on DN4. All are significantly reduced by simply giving vitamin D one shot, 600,000 international units, and the results are as good as treating with duloxetine or pregabalin. So what about diabetic retinopathy? This is often, I think actually, is a condition which is very difficult to treat, particularly because I don't know what happens in this country, but I can tell you even in Qatar, where I'm working at the moment, we don't have a diabetic retinal screening program which picks up disease early. And often what you find is you're firefighting. You're preventing people from going blind when they're actually almost already have significant pathology. But there are data out there that show, for example, the DIRECT study looked at a large cohort of type 1 diabetic patients and treated them with 16 milligrams of candesartan compared to placebo over 5 years. There were two arms of the study. One arm was actually to take patients who had no retinopathy, that is, can you prevent retinopathy if you give candesartan? And actually, they showed that you can. There is a significant reduction in the development of retinopathy if you start treating early. However, if you take diabetic patients who already have retinopathy, then actually treating with candesartan makes very little impact. So there was no significant difference if you already had the complication, whereas you really need to try to treat early. However, there is data, and this comes back to the importance of other risk factors beyond glycemic control. Fenofibrate, again from the field study, showed that if you have randomized patients to 200 milligrams of fenofibrate as opposed to placebo, you can significantly reduce macular edema, proliferative retinopathy, and or retinopathy. And this actually results are better than glycemic control. And yet, I can tell you, if I ask you to put your hand up in terms of whether you use fenofibrate in retinopathy, most people say no, because they use statins and then they forget. And this is emphasized actually so by the fact that now in Australia, fenofibrate has a license for retinopathy, diabetic retinopathy. And another study called the Accord study, which is famous for the fact that improved glycemic control actually caused higher cardiovascular mortality. But there was, within this study, an assessment of the effects of 3 different kind of therapies. So glycemic control, and by glycemic control I'm talking about less than 6% standard compared to 8%. But also dyslipidemia, which is fenofibrate, and antihypertensive therapy. And what did they show? Actually, that by improving glucose control to less than 6%, you reduce retinopathy progression by 33%. However, fenofibrate, 40%. Again, emphasizing the importance. So, diabetic nephropathy, we have many agents for the treatment of blood pressure, but which of these agents actually work for diabetic nephropathy? Well, actually very few. And you see here what's left. So, what can you do with the current therapies that we have at the moment? This is a trial actually published 6 years ago, which I found really interesting. So this is the Superdoses SMART trial. 269 patients with diabetic nephropathy, persistent proteinuria more than a gram a week. Despite 7 weeks of treatment with 16 milligrams of candesartan, they continue to have proteinuria. So what these investigators did, they actually randomized them to 64 and 128 milligrams of candesartan, which is doses that you would never normally use. But actually, what you must understand is that the 16 milligram dose of candesartan is a dose that was approved for blood pressure and not for nephropathy. And so if you use this, what you find actually is really quite impressive reductions of proteinuria. So 64 milligrams, you can see, you get a further 33% reduction, and 128 milligrams, you get 45% reduction in proteinuria. Blood pressure actually no different across the two treatment groups, and one concern, of course, is high-dose angiotensin receptor blockers can give you potassium, but only relate to withdrawal of 11 patients with a potassium more than 5.5. So what do you do next once you're on ACE-ARB, despite adequate blood pressure control? Your patient is coming to see you and they've got proteinuria. Well, the other thing actually you should and can do, and there has shown a benefit, is the addition simply of a dose of loop diuretic, furosemide 80 milligrams. And this is the data actually that did this. So this is proteinuria. This is ramipril 5 milligrams and valsartan 80 milligrams. You can see there's a reduction. But then, if you double the dose of ramipril and valsartan to 10 and 160, you get a reduction. But look what happens when you simply add furosemide 80 milligrams to the lower dose of ramipril and valsartan. You actually get a lower proteinuria than even doubling up the dose. So there is actually, I think, mileage in considering this as an add-on to lower doses of the ACE and ARB. So what next? Well, what next is the addition of spironolactone. Again, people worry about spironolactone and hyperkalemia. But I can tell you there are 2 independent data sets from the STINO that show both in type 1 diabetes and in type 2 diabetes the addition of 25 milligrams of spironolactone actually further reduces urine albumin excretion rate by about 30% without any major problems with hyperkalemia. So really hypokalemia you get when you use the higher doses. So 25 milligrams in the presence of loop diuretics actually doesn't have a major impact. But it does further reduce proteinuria. And finally, what next? Well, the vital study, published again from the STINO, showed that the addition of vitamin D or activated vitamin pyracalcitol actually has a significant impact in further reducing proteinuria. So if your patients are on maximal ACE of hemospironolactone and they are still proteinuric, then considering 1-alpha treatment should further reduce their proteinuria. I think that's it. And this is actually for Mighty. Just to remind you that I originally used to work in Manchester, and it does work. I used to have the pleasure of watching this. Thank you.
Thank you, Professor Mark, for excellent presentation and the new medical information. Can I ask some questions about the triglycerides as a risk factor for neuropathy? Is it directly to triglycerides or low HDL level?
So it's actually triglycerides that seems to. Many studies now show that it is specifically the triglycerides that seem to do this.
And you measured the HDL in this patient?
Yes. So HDL was measured in particularly the field study, and it didn't really seem to have an impact. But there is an independent study called the distance study, which is like 30,000 patients in a big insurance database, and they actually showed again that it was for amputation particularly, it was the triglycerides that were an independent risk factor.
Thank you. Dr. Rafa.
I noticed that there is an indication for the use of vitamin D at a big dose in the treatment of diabetic neuropathy. We noticed in the Arab countries and all areas, all of us, even without diabetes, we have severe deficiency of vitamin D. What is such?
Well, you know, I can tell you, in Qatar is the same, very low levels. So actually, I now prefer to give them, first of all, vitamin D, to raise their vitamin D level to around 50 nanograms. And honestly, I see such a good impact on lowering the pain symptoms. So, you know, instead of using, of course, we have, you know, duloxetine, pregabalin, gabapentin, all these drugs. But first and foremost, it's far easier just to give vitamin D.
Thank you very much. I enjoyed this lecture. But I ask, is it logical to use tramadol, tricyclic antidepressants, and serotonin inhibitors in Arab countries or in Egypt, for example, because the drug abuse and so on? And do you have any comment about that? Thank you very much.
Yeah, I mean, this is a problem that we have actually even in the UAE and Qatar, where pregabalin is now actually banned because people abuse it. You know, my take on it is that if you have a patient, then why should that patient not receive a therapy which we know is effective because some idiot has abused that drug? You shouldn't prevent good treatment being given, and that's what's happening. In Qatar, I can't prescribe pregabalin because the government has decided that there are people abusing this drug. So, I don't know, that's not my problem. You know, that's not, as a physician, I shouldn't be limiting treatment to a patient because somebody's abusing a drug. That needs to be sorted out, you know, at a legal level, at a police level.
Thank you for the very elegant presentation. In my presentation, I was not neglecting the role of other risk factors for prevention of neuropathy. I know. I just was talking to my colleagues treating diabetes, me and our other colleagues working in the field of cardiology. We know the effect of the proper proper management of hypertension, dyslipidemia, hand in hand with the control of hyperglycemic state. My question is, what is the target level of triglycerides to reach to prevent neuropathy?
So this is an interesting question actually, because in the field study, they actually anything below 1.5 millimoles was sufficient. So it wasn't you have to get it really, really low. And they believe actually that it's the triglycerides are important, but probably filofibrate has an independent effect. We don't know what that is yet, but it seems to be improving the neuropathy.
But it's maximum dose of filofibrate you use?
200 milligrams.
200?
Yeah.
Thank you.
You didn't mention what is about the other items in the management of diabetic neuropathy, like the use of the nerve growth factor, alpha-lipoic acid, L-carnitine. They have a role in it.
I didn't mention them because there is no evidence to show that they actually. I know they're marketed and they're used a lot, but my take on it was that I want to only talk about the evidence. And you know, if you look at, there are 4 big trials that alpha-lipoic acid have undertaken, and none of them actually have shown, apart from pain, there is a reduction. There is no effect on neuropathy.